Is that up?
Yep, looks good to me. And we're recording.
Perfect.
So whenever you want.
Great. So now we're going to be heading into week 3, and week 3 means one more week of anatomy. So it's going to be our last week of upper limb. And then after that, we're going to have a week of clinical cases, which is going to be where you're going to be applying all your anatomy you've learned to cases where there's usually a fracture through the arm or some sort of nerve injury, and trying to figure out how that would present clinically and how you would go about treating it as well. But let's start off with the anatomy first, and then we'll move on to our topics in a second. So with the anatomy, it's very much similar to last week. We're going to follow the same structure in terms of looking at the bones, the muscles, the nerves, and then figuring out how that all fits in. Except today, we're going to be talking more about the wrists and the hand. So the wrist joint and the joints of the hand, which are the finger joints, which we'll be learning about in a second. And we're going to start off with a bit about the bones. So in terms of the bones and with your hands and your wrists, we're going to be looking at the ulna and the radius, 2 bones, which we've already talked about last week, but they've been sort of highlighted here as well. One thing you can remember it as is that the radius is on the thumb side and the ulna is on the pinky side. So that can help you sort of remember it if you're struggling to figure out which one's which. And then you also have your carpal bones, which are these bones over here, these set of bones. I'll see if I can get a pointer up actually. Yep, these set of bones here. And it's a set of bones that connect your hand, your forearm really, to the rest of your hand. And this is what we call the wrist joint between the radius and the ulna and these carpal bones. More so the radius, more so the ulna, but those sort of bones articulate over here. But in terms of the names of the bones, they've got a couple of very weird names over here. So the scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. They're always very tricky to remember, but unfortunately, for purposes like clinical skills, you have to go about palpating each bone in the hand and naming them as you go along, or at least talking about them to the examiner as you go along. So in that case, it's sort of a mnemonic that a lot of medical students use, where you start off with the scaphoid, which is sort of at the base of your thumb, and then you go straight, so scaphoid, line to pinky. And so that's the bottom row, which is scaphoid, lunate, triquetrum, and pisiform. And then you go up to the top row and you start going towards the thumb. So here comes the thumb, which is hamate, capitate, trapezoid, and trapezium. And then the thumb there, the THUM, tells you it's going to be trapezium, which is the last one, rather than trapezoid, which is also starting with T. But those are sort of the carpal bones there. And then you also have the metacarpal bones, which come off the carpal bones. So there's carpals, then metacarpals, which are these set of 5 bones here. And then off the metacarpals come the phalanges. And they, again, have proximal, intermediate, and distal parts, except for the thumb, where you just have a proximal and distal part and no intermediate section. So again, those are sort of the bones of the wrist, which is over here, and the hand, which is the rest of this portion over here. All right. In terms of your movements as well with the hand, you have the usual stuff with your wrist. You have flexion, extension. You have radial deviation and ulnar deviation. So if you remember, we said the radius was on the side of the thumb and the ulnar was on the side of the pinky. So radial deviation is deviating your hand towards the thumb side, and then ulnar deviation is deviating your hand towards the pinky side. So they basically have the opposite movements there. And you also have pronation and supination. That's where you're twisting your arm around, but to remember which one's which, think of holding your arm out flat. And then if your arm is facing up, like you're holding a bowl of soup, that's supination. And then if you're turning that around to face the bottom, or with your palm facing downwards, that's pronation, at least in the anatomical position. Then it would be forward and front. But if you're holding it up like that, it's going to be supination here and pronation down. In terms of finger movements, you also have a couple that you have to know about. So abduction and adduction. Abduction is moving all of your fingers away from each other. Adduction is bringing them all together. Extension and flexion can occur at all the individual finger joints. So you can have it at the metacarpal phalangeal joints. You can have it between the metacarpals and the proximal phalanges, between the intermediate phalanges and distal phalanges. So you can have it occurring at multiple joints along the finger. And whenever you're moving it down, it's sort of flexion. And when you're moving back up, it's extension. And with the thumb movements, they are sort of different to your finger movements. So it's important to just keep them in mind. With abduction, you're raising your thumb up, and adduction, you're bringing it back down. And with flexion, you're moving your thumb inwards, like that. You can see that, inwards, and then extension is moving it out. So that's what abduction and adduction is there. So just to reiterate that, abduction with the fingers is moving them out like that, but with the thumb is moving the thumb up. So that's sort of why it's a bit counterintuitive, but just keep that in mind as well for those movements. And then the last two probably that are important to mention are opposition and reposition. Opposition is basically bringing your thumb and pinky together, and reposition is putting them back where they were. All right. So on this next slide, we're going to talk about the muscles of the hand. So last week, Jainam already mentioned a lot of the muscles that influence the hand, and those muscles all started up in the forearm and then went down into the hand. So those muscles we all call extrinsic muscles because they don't start in the hand, but rather they start outside the hand, but then have influence on the hand by going down to it. This week, we're talking about the intrinsic muscles of the hand, and intrinsic basically means that these muscles start within the hand and end within the hand. So these are going to be separated into a number of compartments, but we're going to be looking mainly at the thenar and hypothenar muscles and a couple of other ones as well as the extensor compartment, which again just comes from the rest of your hand. We'll talk about that in a second as well. But let's have a look at those muscles. So when I say the word thenar and hypothenar, they basically refer to a bulk of muscles that are located on the thumb side and a bulk of muscles on the pinky side. So thenar muscles are the group of muscles which are located around about here, close to your thumb, which are all influencing your thumb. Now, the great thing about the muscles in the hand are that the names pretty much give away what they do. So for example, opponens pollicis is a muscle which causes opposition of the thumb. So it allows you to do that opposition movement where you can bring your thumb and pinky together. Abductor pollicis longus is again an adductor of the thumb. And with all these muscles, you can sort of tell where they are. You can sort of figure out which ones they are by looking at where they originate and where they insert. So for example, this muscle over here, I guess very, very to the side over here, where it's sort of going from this part of the bone up to the thumb, is gonna, when it contracts, pull the thumb in and allow for that opposition or even adduction a little bit as well. And then you also have the hypothenar eminence, which I'll talk about in the next slide. But all these muscles have very, very similar names. So sometimes you can use a little mnemonic here to figure out that the thenar eminence has 4 muscles, whereas the hypothenar eminence has 3. And one mnemonic that was taught to us, which was that all for one and one for all, where all for one and those 4 words there tell you the 4 muscles of the thenar eminence, and one for all tells you the 3 muscles of the hypothenar eminence. And again, here's the hypothenar eminence, very similar, but on the pinky, that allow the pinky to be abducted, opposed, and flexed as well. Okay, and now we'll move on to the other muscles of the hand. So we talked about the thenar eminence and the hypothenar eminence, and again, it'll make more sense as you sort of read it and revise it and learn more about the muscles as you practice applying them in the clinical cases. But the rest of the muscles are a bit trickier, so we'll sort of spend more time on them in this lesson. So we'll start off with the palmar interossei, sorry. These are the muscles that cause adduction of your fingers. So if you look over here, you can see the palmar interossei sort of inside your hand over there, and when they contract, they bring the fingers together, whereas the dorsal interossei are located on the outside over here, and when they contract, they bring the fingers apart. So palmar interossei cause adduction and dorsal interossei cause abduction. And the easy way to remember this is PADDAB, which is another mnemonic. So P stands for the palmar interossei and they cause adduction, D is dorsal interossei and they cause abduction. Now with the lumbricals, they're a bit trickier because they have 2 very different movements at very different joints. So at the metacarpal phalangeal joint, so between the metacarpals here and the proximal phalanges, they cause flexion. But at the distal interphalangeal joints, they actually cause extension. So one way that you can go about remembering that is, again, with lumbricals, they start with the L there. So if you imagine making an L with your hand, when you do that, you're flexing at the metacarpal phalangeal joint, but you're extending at the interphalangeal joint, which is again replicating what the lumbricals does. And the reason this actually happens is that the lumbricals have a weird root in the arm where they start off at the front over here, but then they move back into the extensor hood. And so they cause flexion down here at the metacarpal phalangeal joints, but then extension everywhere else. And so that's why these lumbricals, you got to keep in mind that they're doing 2 separate movements, flexion and extension at separate joints. Yeah, so we'll talk about this next one. So with the previous 2 slides, ignore the innervation component of that. With the hand, innervation isn't as simple as it is with the forearm, where you have an anterior and posterior compartment, and the top has one innervation, and the bottom has another innervation. Rather in the hand, it's sort of different, where different muscle groups can be innervated by different nerves. And in particular, with the hand, we only focus on the median and ulnar nerve because they're innervating all of the muscles within the intrinsic muscles of the hand, at least. And you'll notice that with the median nerve, it innervates a lot of the muscles of the thenar eminence, or the sort of muscles under your thumb. And the ulnar nerve innervates most of the muscles of the hypothenar eminence, or the muscles controlling your pinky. So again, to remember all of these innervations, we have handy mnemonics in place with the median nerve to remember that it innervates those thenar muscles and also half of the lumbricals. The mnemonic that's often used is half loaf. So the half L there tells you that it's innervating the medial half of the lumbricals, the opponent's pollicis muscle, abductor pollicis brevis, and the flexor pollicis brevis. So keep in mind, all those muscles are thenar muscles, so the muscles on the thumb side, and none of the muscles are actually going to be on the hypothenar side. So that's an easy way of remembering that it's going to be on the thenar side. And so all those O and A and F are all going to be relating to pollicis muscles rather than to hypothenar or digiti minimi muscles. With the ulnar muscle, the ulnar nerve, the muscles that it innervates are pretty much the rest of the muscles that are left over in the hand. So just think of those half loaf muscles and think about everything else that exists, and that's all going to be ulnar nerve. So again, over here with the radial nerve, it doesn't really have any motor function at all on the hand. The motor function that it has is for the extrinsic muscles that are coming into the hand. So that's what the ulnar nerve is doing, which is that it's innervating everything else except for what's innervated by the median nerve. All right, so just to explain that in a bit more detail and to help understand why the median nerve is doing the thenar muscles, whereas the ulnar nerve is innervating the hypothenar muscles, you can sort of generally take a look at the nerve roots of these muscles, of these median nerve and ulnar nerve. So if you look at median nerve, you notice that it sort of comes down the arm, but when it goes to the hand, it spreads out near the thumb side, which is why you have all the lateral side, which is why you have all these muscle groups in the thenar eminence being innervated by that median nerve, so the half loaf muscles. Whereas the ulnar nerve is entering into the hand on more of a medial side, or the pinky side. And as a result, it's innervating more of the hypothenar muscles, or the non-loaf muscles. But one weird thing it does do is that a branch of the ulnar nerve does sort of come around and innervate the thenar eminence, but only one muscle, which is the adductor pollicis. And the way that I sort of remember it is that, first of all, it's the most distant muscle from the thenar eminence. And so it's the most closest to the ulnar nerve, but also something which is often stated as its function of the ulnar nerve, or as one of its roots, is that the adductor pollicis muscle is often called the ulnar graveyard. It's basically a location where the ulnar nerve terminates. So if you ever want to remember that the only thumb muscle, or the only thenar muscle, which is innervated by the ulnar nerve, it's going to be that adductor pollicis muscle, which is the ulnar graveyard. And with the radial nerve, just keep in mind that it's going to have no function at all in terms of motor function in the arm, or the hand, but it does have motor function in the forearm. And again, those forearm muscles go into the hand, which is why it still does have some role there with extending the digits. And sensory innervation wise, again, if you look at the way the nerve enters the hand, you can also see why the sensory innervation is also very similar. So with the median nerve, it's got those lateral 3.5 digits, whereas with the ulnar nerve, it's the medial 3.5 digits over here, which is these two images should be swapped, but I'll change that afterwards. So this one over here is the ulnar nerve, and that one over here is the radial nerve. And with the radial nerve, it's sort of the dorsum of the hand, so most of the back of the hand, because of the way that it enters the hand again. And it's not really going to have much bearing sensory-wise on the front of the hand at all. And the next slide here is just showing one of the regions that we look at in anatomy, which is the anatomical snuff box. And it's located at the dorsum of your hand. So if you were to get your hand like this and sort of extend all your fingers as much as you could, you'd find a small depression, a concave depression, at the base of your thumb, on the dorsum of your hand, which we call the anatomical snuff box. And this is a sort of important landmark on the body, which we sort of have a look at the boundaries for and the borders for, but mainly because it's also a location where we can easily find the scaphoid bone from, but also because it's also another region where the radial nerve has sensory innervation of. So the lateral medial boundaries in the roof and the floor are all labeled here, so I won't go into them. But you can see why the floor is important, because at the base, or just if you palpate deep into that area, you can actually feel the scaphoid bone there, which will come in handy when we look at scaphoid fractures later on. But also, in terms of the lateral and medial boundaries, you can see that the abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus are all sort of lined up along here. And one extra thing you should keep in mind as well is that this is sort of arranged in a longus or a brevis sandwich style arrangement, where you have longus muscles on either sides and brevis muscles in the middle. So you have abductor and extensor pollicis longus on either side, and in the middle between them is extensor pollicis brevis. All right, and next up we have another region in the hand called the carpal tunnel, which is just a passageway for structures entering the palm. And you can see over here in this diagram on the left that we've taken a section through the hand, and this section is going through most of the carpal bones, except for maybe the scaphoid here and the lunate bone. But every other sort of carpal bone is being cut through, so you can see them being labeled here. And just above the carpal bones, we have the anterior part of the arm, or the palmar part of the arm. And behind those, or under them, is the dorsal aspect of the arm, where the extensor tendons will pass through. So above you have the flexor tendons, and below you have the extensor tendons. But also you can see in this area, which is called the carpal tunnel, is the median nerve, right? And that's going to be important when we look at carpal tunnel syndrome. Before we do that though, the upper boundary of this area is a ligament or a flexor retinaculum, and it's often called the transverse carpal ligament, but it forms that roof of this tunnel. So here is the carpal tunnel. And again, the contents, just to reiterate, is the flexor tendons of digits, as well as flexor pollicis longus. And you also have over here, the median nerve. And one side note as well is that something you'll go over in your tutorials is that the ulnar nerve actually passes into the hand as well, as we saw before, but it passes through a different passageway. It goes through this area called Guyon's canal, which is superior or superficial to this carpal tunnel. And what that means is that often whenever the carpal tunnel is affected, the ulnar nerve is going to be unaffected, because it's sort of going through a separate area where the pathology which is presenting here is unlikely to affect this area up here. All right, now let's talk about some actual clinical relevance to all this anatomy. So in terms of the clinical relevance over here, with carpal tunnel syndrome, it describes a set of symptoms caused by carpal tunnel compression. So before we saw that the carpal tunnel was a sort of passageway that allows the median nerve and the flexor tendons to all enter into the palm of the hand. But what can often happen is that those contents can get compressed inside the carpal tunnel. And an example of how that could occur is if you have a swollen flexor retinaculum. So we saw before in the previous slide that the bridge, or the roof, sorry, of our carpal tunnel was formed by the transverse carpal ligament, which is a type of flexor retinaculum. If that becomes swollen, it can push down on the median nerve under it and cause it to have pathologies, which we will see in the arm later on. But another reason that can cause this is lunate dislocation, where when you have a fallen or outstretched hand or a Fuchs injury, then the bones of your arm, so your radius and ulna, can actually push down and cause the lunate bone to dislocate anteriorly, and therefore compress that carpal tunnel and cause the same pathology that we're going to be seeing. So either way, you can have the contents of the carpal tunnel becoming compressed. And as a result, because the median nerve is within the carpal tunnel, it's also going to become compressed. And the median nerve is innervating some key muscles in the hand. And as well as that, it's also got some sensory components that are going to be innervating the hand. And so if you have median nerve injury, you're going to have loss of those motor components, and also some thenar wasting and sensory loss as well in the hand. Next up, we have fractures of the scaphoid bone. So the fractured scaphoid bones are another sort of thing that we look at, which, because in particular with the scaphoid bone, it's at greater risk of avascular necrosis. So you can fracture many other bones of your hand, but this bone in particular has a greater risk of avascular necrosis or cell death, because of a lack of vasculature, sort of giving it nutrients and taking away waste, because of the way that the blood supply is passing through it. So rather than the blood supply is just going from proximal to distal, so going from here to here, the blood supply actually goes around and goes from distal to proximal. And what that means is that whenever a fracture fragments the scaphoid bone and causes it to become two separate pieces or even more, it means that the proximal fragment has no blood supply, while the distal fragment will have blood supply. And what that means clinically is that that distal fragment still is able to receive blood, and so is therefore able to heal properly. Whereas the proximal fragment over here, which is losses blood supply, is not going to be able to heal as well, and is therefore susceptible to avascular necrosis, which is why it's very important that these fractures are diagnosed promptly and are dealt with promptly as well. All right, this is probably the ones that I want to spend the most time on with the clinical relevance, because this describes all the different nerve damages and how they can affect the hand. So admittedly, it's very confusing to learn which nerves innervate which muscles, but once that all starts to make sense and you realize that the median nerve is innervating those half-loaf muscles and the ulnar nerve is doing everything else, it can be easy enough to understand how injuring the median nerve or ulnar nerve is going to affect the movements at the arm or at the hand even. So if we look at the median nerve and damaging the median nerve, if that damage is distal, which means that it occurs distally, so away from your body and close to your arm, what that means is the median nerve is going to lose its innervation to the lateral half of the lumbricals. Because if you remember, the median nerve was innervating the lumbricals, but only the lateral half, or the half which is on the thumb side. And what that means is that you're not going to be able to extend those digits, right? And as a result, you're going to get what's called the hand of benediction, where when the person is trying to flex those fingers, they're unable to do so as well. Okay. And with proximal nerve damage, I think this might actually be swapped around, but I'll have a look at that afterwards as well. But with proximal median nerve damage, so it's where it's higher up, so closer to your body, you're also you're gonna lose those lateral half of the lumbricals, but you're also gonna lose the lateral half of the flexor digitorum profundus muscle. And what that means is you're gonna have weakened flexion of the lateral half of your digits. And that manifests as when the person tries to close their hand, and make a fist, then they're able to flex pretty much every single digit except for the lateral half. And with the ulnar nerve damage, it's a very similar idea. You have a look at the muscles affected and then look at the actual result. And with the radial nerve, it's much simpler because the radial nerve is only innervating muscles in the extensor compartment of your forearm, which are going down into your hand. And so damage to the radial nerve anywhere along here, before it innervates those muscles, is going to cause your hand to have a wrist drop because the extensors aren't able to extend your arm and cause a normal posture. Instead, your arm drops down because the flexors dominate. All right, that's basically the anatomy that we covered. I've sort of tried to keep it short and concise, and you can always have a look over the slides again to really memorize those muscle innervations. But just keep in mind that not a lot of it's going to be highly relevant for what you're going to be covering in your classes. Rather, there's only a couple of very important points that you want to remember, like particular muscle groups that are affected by particular nerves, but every single thing is not required to be memorized. And I'll pass on to the next person.
Yes, thanks, Janil. Do you mind stopping sharing? And then yeah, perfect. Okay, I'll share my screen. So I'm going to be covering, it says host disabled participant screen sharing.
Sorry,
I might not be a co-host. That's okay.
Yeah, I usually make you a co-host. Sorry.
All good.
There you go.
Yeah, awesome. Let me share my screen. So today I'm going to be covering bacterial pathogenesis, which is actually a fairly straightforward subject. And, this will be followed up with viral pathogenesis and then some of the other types of infections that you can get in the musculoskeletal system and so on. So this sort of sets up a good foundation for what you'll be covering in later weeks. Although I will admit a lot of it can be quite frustrating because there's a lot of different categories of information that you need to remember. I will try my best to highlight the most high yield and clinically relevant sections, but I do admit that a lot of it is not actually that relevant to your exams or your later studies. But as I said, I will point out the things that are most important. If you have any questions as well, just type them in the chat and I'll get to them as soon as I can. So starting off with a few definitions, this might be stuff that you may have covered last semester, or it might be just stuff that you're familiar with from your previous studies. We know what a pathogen is. It's any organism that's capable of causing disease. And this is not just bacteria, it can be viruses, fungi, parasites, and so on. And pathogenesis is a word that means the process by which that organism is then going to be able to cause disease. Now, how does a pathogen cause disease? Well, we look at this idea of virulence. Virulence is a measure of the ability of an organism to cause disease. So if a particular pathogen is very high virulence, it's probably going to be able to cause disease to a much, either more quickly, or it's going to be a more severe infection that it's going to cause. Virulence factors, on the other hand, are actually the tools that the pathogen will use to allow it to cause disease. And that's going to be the major focus of today's session, is the actual tools that all of these different bacteria use to get into your body, to be able to infect certain cells, to be able to evade your immune system, and all these different features that they can express. And then finally, a bacteria, very basic definition, and you probably would have covered this last semester. It's a prokaryotic unicellular organism that has no nucleus, or no defined nucleus, and no organelles. Now, it's really, really crucial to remember, and I think there's a lot of stress placed on this in your lecture, is that not all bacteria, and in fact, not all viruses, not all parasites are actually going to be pathogenic. There are many, many species that definitely form sort of your natural microbiota. In fact, they can be even beneficial to you. So they can actually provide us a layer of immunity. So the most common example that I use is ones on the skin. If you didn't have those bacteria crawling all over your skin, it would mean that optimistic infections, or like foreign bacteria, will be able to find some sort of free land or free real estate, and then be able to colonize your skin, right? If you didn't have all those bacteria, which is why it's really crucial to maintain that natural microbiota. However, the major focus is definitely in this session going to be all those bacteria that are causing disease. Here are just a couple of slides to give you some idea of the diversity of the bacteria. You can see there's many different shapes and sizes and all the different virulence factors that they express. And then a little diagram at the bottom just showing you where bacteria are placed in the entire kingdom of living organisms. So they're not eukaryotic, they're definitely prokaryotic, and there's so many different types, as you can see. All right, and another summary slide. I think this diagram on the left just shows you the different bacteria that cause, or most commonly cause, certain infections. You will definitely not need to remember any of this. I just put it as a bit of context. You will see all of these come up in your later studies. So I didn't know anything about urinary tract infections until this year when we were covering kidneys and the urinary system. And that's when I realized all of these different bacteria. At this stage, it's probably just important to maybe think about some of the skin ones, as well as some of the musculoskeletal ones, which are not really shown here, but you will come across them in later weeks. Okay. Just a fun little trivia fact. You have 1.3 bacterial cells for every human cell. And you also have 100 trillion total bacteria. Again, like 90 to 95% of those are going to be your normal bacteria. It's also really important, this is probably the most important takeaway from this slide, is that there are certain sites in your body which are sterile. In fact, like, in other words, they shouldn't contain any bacteria, viruses, any sort of pathogens. If you do find any bacteria within these sites, that indicates that there is some systemic spread of infection. So these include things like blood, shouldn't have any bacteria. You've got urine, in fact, sort of the upper urinary tract shouldn't contain any bacteria. You've got the cerebrospinal fluid, so you don't want things around your spine or your brain. Lower respiratory tract, it shouldn't be able to get so far deep because you've got a lot of mucus that's going to trap those bacteria. And bone as well shouldn't contain any bacteria. So you'll discuss things in MSK infections where you've got bacterial infections of the bone, which is not normal. Okay, now on to the actual bacterial stuff. So these next couple of slides, I'm going to be talking about the different stages at which bacteria will cause disease. And it generally occurs in 3 stages, or at least that's the way I like to think about it to make my studying a bit easier. I like to think about invasion, evasion, and damage. So invasion is just the ways that the bacteria get into your body in the first place. And we'll talk about adhesion factors, degradation of the host systems, entry into the cells. Evasion is how it manages to escape from our immune system. So how it avoids immunity, how it avoids getting eaten by the phagocytes that are sort of monitoring the bloodstream or monitoring tissue. And then we've got ways that this is not what all bacteria do, but in order to cause disease, they can actually lead to damage to the host structures. so through toxins, superantigens, and so on. So we're going to discuss each of these in turn. All right, so adhesion. These are just ways that, so if we need a bacteria, if you get a bacterial infection and it has some hope of trying to stay in your body, to be able to take some of the nutrients that you're taking in and to be able to cause some sort of damage to be able to grow, it's going to need to stick for at least a specific amount of time. Otherwise, if it wasn't able to adhere to the inside of your mucous membranes, it would just be flushed out immediately, which is not ideal for the bacteria. There are two major types of adhesions that you can get. We've got the fimbrial adhesions and the afimbrial adhesions. Now it's really simple. So the fimbrial adhesions, you've heard of fimbria, it's like these little projections that come out of cells. In this case, we're specifically talking about bacteria. It's going to be indirect contact because it's not actually physically touching your mucous membrane. It's touching it through these little hair-like extensions and structures. The afimbrial adhesions are direct physical contact. So they don't have any of these hair-like structures. They just connect straight away through adhesins on the surface. It's really important to remember that both of these have adhesive tips. It's just that one of them is at the end of a hair-like structure, whereas the other one is not. So surface, and this is indirect. Here are a couple of examples. I put examples of bacteria mostly in boxes to indicate that they're not actually that important to remember. I didn't really remember which has fimbrial, which has afimbrial, but it puts a lot of context into why we're talking about this in the first place and that they actually exist. So Neisseria gonorrhea, the bacteria responsible for obviously gonorrhea, it has fimbrial adhesions. And of course, the tips, as I said, contain adhesin, so it allows it to stick to the mucous membranes. Pertussis, so the bacteria involved with that is Bordetella pertussis. It has afimbrial adhesions and it sticks to mostly the mucous membranes on cilia. So it attaches to them and then it paralyzes it, which is why in usually younger toddlers who do contract pertussis, you get difficulty coughing up mucus and difficulty coughing up bacterial pathogens because it's able to paralyze those cilia. And Staph aureus, I think, is just the catch-all. So if you ever need to guess in any exam, like which bacteria causes what, and one of the options is Staph aureus and you're not sure, just pick that because Staph aureus has a lot of different tools that it uses. So it's a very, very dangerous one, but it's also quite common because it's just found on your skin, it's found in your throat in a lot of different places. So in Staph aureus, like in this context, it coats itself in the host extracellular matrix. So it's kind of tricky in that sense. And so if it hosts itself in the ECM of its own host, then it's able to stick a little bit more easily to your host cell membranes. So it's a smart one. And you'll see it pop up many, many times in the next couple of slides and in the next few weeks. Just as an extension of the previous slide, you will also be able to have capsules on the outside of bacteria. So this is outside of its plasma membrane and its cell wall. And this contains what we call a glycocalyx, which is just a hydrated polysaccharide. What this is useful for is it helps further adhere to host surfaces. So even if you don't use the fimbrial extensions or all of those hair-like projections, because of the sticky nature of the bacterial capsule, it's just able to really easily adhere to the surfaces. If it's able to do this effectively and not be cleared out, it'll actually be able to not just form colonies, but also evade the immune system. Because what the immune system requires is direct contact with the structures on the outside of the bacteria to be able to identify what it is, right? And if you've got this sticky layer on the outside preventing you from having that contact, it'll make it easier for the bacteria to evade immune destruction. Biofilms are probably the most important one to consider. Because if you think about, for example, I'm trying to insert a artificial, like a hip replacement into someone. If I don't make sure that that hip replacement is completely sterile, I could get the formation of a biofilm on that joint socket. And if I'm trying to insert that in, that's going to be very, very problematic because as soon as I insert it and I close up the patient, I'm going to get probably sepsis or like some sort of bacteremia where the bacteria is just able to spread really, really effectively. Biofilms are very dangerous. It's the reason why they're so dangerous is because it's bacteria that are sort of grouping up into a really big army. So there's hundreds, thousands, millions of bacteria that are sticking together. And so the previous ones we're talking about bacteria sticking to host cells. This is literally bacteria sticking to each other and forming a really, really thick mat. This can lead to things like severe inflammation. We'll talk about sepsis in the last slide, so ignore that term for now, but it's a very, very crucial one to look out for. And it also makes it difficult, of course, for immune cells to get in, because if you've got an entire clump of bacteria, the immune cells are going to have to chip away slowly from the top. from the outside to the inside. And it even makes antibiotics very difficult. So you want to really make sure that if you're inserting something into a patient, that it's free from having any biofilm or any possibility of a biofilm formation. These are just sort of 3 examples, but really I'm pretty sure most bacteria can form biofilms. It's just that these 3 ones are crucial to look out for in a clinical environment. So you've got nosocomial infections that you can get in a hospital setting. Oh, and also just to go back to the previous slide, all of this stuff on the outside is the capsule. So this is the inside, that's the actual bacteria. This massive thick bit around the outside is the capsule. So you can see how difficult it is for things to get in through the capsule and attack the bacteria itself. So these are the antibiotics or the immune cells. Now we talk about degradation. So I'm not talking about destroying cells most of the time. I'm just talking about ways that bacteria are able to invade. So they're degrading structures to be able to invade into your body. So this can be host structures or defense mechanisms. Now, there are a lot of enzymes that I'm going to talk about. Again, it's not so important for you to remember the enzymes, but perhaps attach one example in your mind to each of these processes so that you at least know, for example, with urease, if you know that it's mostly with H. pylori, then that'll help you remember, or even if you just remember this diagram, it's very, very useful. You don't need to specifically remember the effects of each of these enzymes, but for completion's sake and for your own revision, I've put in the names. So for the ECM, the extracellular matrix, if a bacteria is able to degrade that extracellular matrix, it starts off on the top of your epithelial layer. So if you think about skin, but if it's able to degrade down into that extracellular matrix, it's going to be able to enter into deeper layers. And so it goes deeper and deeper and deeper until it's able to get to your bloodstream. And from then forward, it's basically like a celebration for the bacteria. It's able to go anywhere that it possibly thinks about, right? So that's like the best case for a bacteria to be able to get as deep as it can. There are 2 enzymes that are involved. Collagenase breaks down the collagen layer. So in an epithelial layer, the collagen layer is what actually, it's like the strong part, right? It's able to really block out anything that's trying to get through. So you've already broken down the collagen, which makes that layer a little bit weaker. And then you've got hyaluronidase. It's very difficult to pronounce. It's actually going to directly degrade the ECM. So you can see how both of these sort of work together. First of all, I'm degrading the collagen, also degrading the ECM, and it's able to get down to this really, really deep layer of the epithelium, by which time it's invaded well and truly. Urease is, as I mentioned, it's quite specific to H. pylori, or at least for our purposes, it's most important to discuss with Helicobacter pylori. You will cover this in a lot of different subjects, actually. I think it even comes up in population health. So you'll get to know about H. pylori quite a bit. But the main takeaway here is that it produces an enzyme called urease. This enzyme is able to neutralize stomach acid. So you've got H. pylori like invading into the stomach acid. What's interesting is that most of your bacteria that you eat will die in the stomach acid. But H. pylori is very persistent and very annoying. So it neutralizes all of this and it degrades into the mucosal lining of the tract itself. So you can see how it sort of goes in and burrows into the mucosal lining, and then it is able to reach the epithelial cells themselves. It does this by creating an ammonia cloud. So that the ammonia, of course, is a base, so it's doing the neutralizing, but it also damages the surface lining and it's able to burrow in. It's actually one of the main causes of stomach ulcers, and stomach ulcers then, or the H. pylori is also a very predisposing factor to stomach cancers. So it's a super crucial one that you will come across next year as well. Okay, so that's urease. Then you've got things that are involved with coagulation. This is not so much for damage. It's actually a kind of response to hide away from the immune system. So you've got 2 enzymes again. You've got coagulase, streptokinase. They're both working together. And it's really simple to think about, because what coagulase does is that it allows for the clotting of blood. So you can see what coagulase is doing here. You've got these bacterial cells going out of the bloodstream, and it's actually causing a clot to form. So it's converting fibrinogen into soluble fibrin. I'm not sure if you guys have covered hemostasis and stuff yet, but if you have, then you might know what all these terms mean. It's converting it and like basically promoting a blood clot to form. So you've got this clot forming. And if this clot forms, it means that any immune cells that try to escape and attack the bacterial cells, they won't be able to get past the clot. So effectively, it's hiding from all the immune cells. And then once the bacteria thinks, okay, I'm free to go, there's no immune cells left, they've all kind of given up, then it'll produce streptokinase, and that acts to dissolve the clot. So it's able to re-enter back into the bloodstream. So super, like it's a really interesting mechanism. So it's hiding and then it's able to re-emerge again. And one of the main bacteria that does this, of course, the catch-all, which is Staph aureus. Okay. Then you've got some mechanisms for escaping the immune system. That was basically the immune system as well, but a couple of extra ones. I haven't gone into a huge amount of detail just because I don't think you do go into that much detail in your lectures. But if you want to research this or look for diagrams to just supplement your learning, definitely go ahead. You've got IgA protease, and what that does is the IgA immunoglobulin A. This protease enzyme is just going to be able to break it down. So it's going to cleave all the antibodies that are produced by your mucous membranes that are acting to try and flag those bacteria to the immune system. You've got DNase, which it's nothing to do with DNA. It breaks down the neutrophil extracellular traps. So I don't really actually know what these are. I just like to think of them as nets released by neutrophils. And what this DNase enzyme does is just breaks it down. So it prevents your bacteria from getting caught in those nets. And then finally, you've got complement degrading systems. So you've got your complement proteins that are also assisting with the humoral aspect of your immune response. And if you've got these enzymes or proteins that are able to degrade the complement system, it's going to help with evading from the system as well. So you won't just have bacteria that express one of these. Most bacteria will express multiple virulence factors, and that's what makes some of them really, really dangerous, especially Staph aureus. Okay, so it's not a one-off thing. They will just contain many of these procedures. Now we come to entry. There's two main mechanisms by which bacteria will enter into cells, and they're called the zipper and trigger mechanism, which makes it really simple. You might notice that in anatomy and physiology, microbiology, a lot of things are named based on like other people's names, like people who discovered it, or just like Latin or something. This is probably the easiest one to remember because it very literally describes what's happening. So the zipper mechanism is as displayed up here. It's when you've got your bacteria coming in, it's attaching its adhesins to the receptors on the top of the of the host cell. And the membrane itself is able to curl around and engulf that entire bacterium. Now, of course, the host cell doesn't want to do this, but the bacteria is quite tricky because what it does is when it attaches, it forces there to be signals within the host cell. And the host cell thinks that maybe this is just, a protein that I need to digest, or it's a carbohydrate that I need to take in. So it's like sort of endocytosing the bacteria, thinking it's a normal thing that it needs. So this is something that is displayed in bacteria such as Listeria monocytogenes, and the one we mentioned before, which is the bacteria responsible for gonorrhea. The trigger mechanism is a little bit different. And this one is really easy to remember because it's kind of like your bacteria has these injections on it, or what we call molecular syringes. The main one that you will discuss is TS33. Oops, I think it's actually supposed to be T3SS, not TS33. But there's so many different names that TS33 probably exists somewhere. The main one is T3SS though. So if you see that in an exam, just remember it is a molecular syringe. The bacteria actually just comes in and pokes into the membrane. And through this way, it releases its own factors. So remember in the previous one, how the bacteria comes up and it forces when it attaches to the receptor, it forces the host to be able to produce its own signaling molecules. With the trigger mechanism, the bacteria is actually injecting its own molecules. And this will trigger the host cell to think that, again, this is a normal thing. This is a normal molecule that I need to endocytose. And it will come about, it's called membrane ruffling, but it pretty much does the same thing as the previous one. It's going to engulf the entire bacteria. In the end, both of them are going to be in their own little endosomes, okay, in their own little vacuoles. This will include bacteria such as those that cause Shigella and those that cause Salmonella. Again, the examples are not so important. So if you are struggling to remember which is which, I think these diagrams are really, really important. But usually what I like to think about is that zipper is from outside. So the bacteria is coming in from the outside and it's causing host signaling molecules to be produced from the outside. It's not actually inserting anything in, right? Whereas the trigger mechanism is actually injecting stuff into the cell. And so it's causing internal changes to the cell, okay? You might also notice that you've got this G-actin, F-actin. These are basically just the proteins that are responsible for the ruffling of the membrane. So they're going to polymerize, they're going to be forced to polymerize and then come around and engulf the entire bacteria. That's the zipper and trigger mechanism. All right, bacterial evasion. So this is how the bacteria is able to avoid getting destroyed by the immune system. If you guys recognize any of these shows, pop them in the chat. The top one especially, one of my favorites. But these are just sort of the ways. So like there's basically 3 ways that you can get evasion from the immune system. And you don't really need diagrams because they're quite easy to understand just from the wording itself. So you've got antigen mimicry and you've got host mimicry. With antigen mimicry, this is basically where the pathogen will continuously change its antigens. Remember what antigens are. It's just stuff that's displayed on the surface of the bacteria or whatever the pathogen is, and that allows the immune system to be able to recognize them. So if my bacteria is able to change these antigens very purposefully, it means that antibodies, even if my immune system recognizes them, makes antibodies, within a couple of minutes, my bacteria now displays new antigens. And so those antibodies are ineffective and cannot bind. Host mimicry is a little bit different. This is even more sinister. It's sort of where the bacteria displays on its own surface antigens that are the same as what the host cells will display. So in the capsule or in the membrane, it's going to imitate some of the host polysaccharides. And remember what we talked about with Staph aureus. This can either be by the bacteria actually going into a cell and then being able to code itself in what the ECM of that cell was, or it contains genes that are able to screen for all the different antigens displayed by the host and then replicate them. So it's a very, very tricky mechanism, but now the host just thinks this is normal, right? And it's not going to even try and launch an immune response. Whereas with the antigen mimicry, it'll at least try every single time the antigens change. And then avoiding phagocytosis, I've got a diagram that I've drawn on the next slide, but these are ways that bacteria will avoid neutrophils and other phagocytes. And there are basically 2 main mechanisms by which this can happen, either through intracellular mechanisms or extracellular mechanisms. And those are sort of shown in the, I've added a slide first on phagocytosis. I'm not gonna spend too much time on this. I believe you've probably gone over it last semester. All the different stages that you have, activation, chemotaxis, ingestion, digestion, and then exocytosis of all the waste. Basically at each of these stages, you can have the bacteria doing something to prevent that stage from going on to the next. So we're going to go into that in the next slide, but just make sure you have this in mind because it'll make the next slide a little bit easier to understand. So maybe keep the slide open when we're going over the next one. Here is the summary that I drew for myself last semester. I think there was a diagram in your slides, but it probably was like a little bit pixelated, so I just drew my own. You've got the extracellular mechanisms on the top, and you've got the intracellular mechanisms, so 3 of them on the bottom. You've got one where you're able to release cytokines to lyse the phagocyte. This is just direct damage. So it's releasing proteins, or it's releasing signaling factors, and it's forcing that phagocyte to basically just kill itself, to apoptose itself. Some bacteria include Staph and Strep species. You've got this other interesting one where you've got bacteria able to neutralize the FC portion of antibodies. So the FC portion is sort of the binding portion of the antibodies. So if my bacteria, and then there's like proteins, like for example, protein A, which allows it to bind to that FC portion, that will prevent those antibodies from, first of all, whenever they're produced, it's going to prevent them from binding to the phagocyte, or from the phagocyte to be able to actually identify those antibodies. So it's effectively neutralizing them. And then you've got the capsule. So if I just make my capsule thicker, or if I make it a bit more difficult to penetrate, if I have factors on them that make it look like I'm part of the host, then that's going to prevent any interaction or any hope of interaction with the immune cells. This is all happening from the outside. The dangerous one is where the cell or the bacteria is actually able to enter into the host and still not able to be destroyed. So these are actually quite dangerous. So the first one is where you have the bacteria going into the phagocyte, but it's not going to be able to fuse with the phagosome and the lysosome. So remember what we have, right? You've got endocytosis of the bacteria. It's going to have to fuse with the phagosome, and then it's going to have to fuse with the lysosome. Those phagosome, lysosome form the phagolysosome. Contains all these different molecules that are able to degrade the bacteria. It contains hydrogen peroxide, contains catalase, all these different things. It's got an acidic environment, all that stuff being thrown at the bacteria to be able to basically destroy it, right? If you prevent the fusion from even happening in the first place, then you basically will have your bacteria being stuck in a vacuole, and then it's going to be able to move wherever it wants. That's what we call intravacuolar or intravacuolar. One of the major ones that actually does this is Mycobacterium tuberculosis. So it's able to chill around in the ECM of your phagocyte and then pop out and keep replicating. Okay, so it's not going to be affected by the lysosome at all. You've also got this second one where even though you've got the binding happening, so you've got the bacteria coming in, it binds with the phagolysosome, it still is able to escape. And there are many, many factors that can be involved in this. I won't go into all of them. I think your slides, like lecture slides, will probably be enough. But it's able to escape from the actual combined vacuole that's made. And so basically the vacuole will stay there and the bacteria is able to escape into the cytosol. So we call this a cytosolic invasion. And one example of this is T. cruzi. And then finally, you've got, this is probably the most overpowered one. You have the phagolysosome binding with the bacteria, everything goes right, but for some reason your bacteria are just so strong that it's able to resist destruction by the phagolysosome. So for example, if it's an acidic environment within the phagolysosome, your bacteria could just be highly resistant. It has a really strong capsule, or it's producing basic or alkaline materials to be able to neutralize those. If your phagolysosome contains enzymes, this is able to cleave those enzymes and prevent them from even being able to destroy the cell wall of your bacteria. So it actually contains a lot of different virulence factors that make it really, really difficult for the phagolysosome to actually go about digesting. In this case, your bacteria exists within the lysosome, so we call them intralysosomal. Again, staph is a very important one. It uses catalase to break down hydrogen peroxide, which is within the phagolysosome. Basically, all of these mechanisms will make it very difficult for our body to recognize and mount an immune response. I think I've added in this bit here at the bottom as well, just for your own interest. If you've got something that exists within the cytosol, it's kind of annoying for the bacteria because it's now surrounded by all these organelles. It's in a very viscous fluid. And if it doesn't have any of its own cilia, it's not going to be able to move around and do anything. So what the bacteria does is it actually forces those little actin proteins that are located within the cytosol and signals to them to polymerize behind it. So it's a little bit of physics, but what it does is that it forces the things behind it to be able to be built, and that propels so like equal and opposite forces, it propels the bacteria to move forward every time something is built behind it. So it's not actually directly propelling it forward, it's very indirect, but the effect is still the same. It's kind of like if you had cilia, it's able to move around wherever it wants. It's going to then go on to invade other cells and replicate even more. Okay, so think about it in these two groups. One is from outside, and there's 3 of them, and one is from inside, and there's 3 of them. This is very, very important. So this will be very important for when we discuss sepsis. Whenever your bacteria continue to want to damage, it's going to try and produce things called toxins, endotoxins or exotoxins. And these are the molecular weaponry that it uses to damage the cells. It's very important for you to understand the difference between each of these terms. So anytime I think of endotoxin, I'm thinking about within the bacteria, or like it's sort of part of the bacteria. So in this case, endotoxins, first of all, they're only produced by gram-negative cells or gram-negative bacteria. And we'll go into why in just a second. The second thing is that they're only released when the bacteria dies. So it's kind of like a fail-safe mechanism. Even if the bacteria is doing a bunch of damage and then eventually immune cell finds it and kills it, it's kind of like a last hurrah. It's able to release these endotoxins and still cause quite a bit of damage, release into the bloodstream and so on. So the reason why it's only in gram-negative is because it binds to, or it's part of the LPS component, or the lipopolysaccharide component of gram-negative bacteria, which is not found in gram-positive, or at least it's not found in a significant quantity. The main active part is the lipid A part. So you've got this lipid A component. Again, you don't need to understand all the different parts of the endotoxin, but as long as you understand that this bottom, like the basal bit or the base part, which is the lipid A part, that's the actual part that's causing damage. The rest of it is mostly just for like signaling and other processes. The exotoxin, exo meaning it's outside, so it's actually something that starts within, but it's actively released. So this is not when it dies. The exotoxins can be released throughout the lifetime of a bacteria. This is why it's also able to be produced in both gram-positive and gram-negative, because as long as you have all the machinery to develop these exotoxins, any bacteria can do it. So any bacteria has the capacity to produce exotoxins, but endotoxins are specific only to gram-negatives. Superantigens are very interesting. So all they do is they try and get the immune system to be so overactive that the antigen itself or the bacteria itself is not producing any damage. It's actually your own immune system that's causing most of the damage and leading to destruction of your own cells. So you've got, like this is just a diagram showing what the superantigen looks like. So you've got, this is the superantigen. This is the superantigen on the side. What that does is that it forces the T cell receptors to really, really strongly bind with the receptor on the antigen presenting cell. So basically it's causing your T cells to be continuously activated. So usually what you get is just a little bit of binding, then they dislocate from each other, and then the T cell goes on to launch an immune response. But if you keep on having this activation, it's going to mean that the immune system is way too overactive. So it's a non-specific bacterial antigen, which means that it's just able to cause any of these interactions to be prolonged for too much of a time. There's a couple of figures to show you how extreme this can get. In a normal immune response, you only have 0.001% of T cells being activated. But with the effect of superantigens, you can get more than 20 to 30% of T cells being activated. This is very, very dangerous because it causes what we call an en masse activation of T cells. T cells, of course, are quite useful, but if you have overactivation, you can get too many cytokines being formed, you can get excessive inflammation, you can get what we call toxic shock syndrome. This is related to sepsis, and I'll go into that in the next couple of slides. You can even get multiple organ failure because you have too much vasodilation, you have too many immune cells going in, you've got too many phagocytes, all this different, you have way too much blood flow going into the different organs, right? So that's going to possibly cause organ failure. One of the main examples, this is probably the most useful one to remember out of the previous couple of slides, is Staph aureus, and it's typically due to unsterilized tampons. So if you're using unsterilized tampons, then you can get a biofilm of Staph aureus forming into it. You're basically giving it access to the mucosal membranes within the vagina, and then it's going to be able to go from there into the bloodstream, going to release all the superantigens and cause toxic shock syndrome, which is not a very good thing. But of course, the prevalence of this sort of transmission has become very, very slowed down. So the reason why is because we've been much more cautious with the way that we're producing tampons, or at least handling and packaging tampons. And then finally, you've got surface toxins. So these are found on the surface of bacteria. I've got an example here of a pore-forming cytolysin, but you can search up all these other ones to just have a look at what they look like. With the phospholipase, we know that your membrane contains phospholipids, and that's what maintains the integrity of the cell membrane. Of course, bacteria also express an enzyme that's able to break down the phospholipids. If you break down the phospholipids, suddenly, remember, phospholipids are like most of the cell membrane. So if I destroy it, I'm effectively breaking down those walls, allowing stuff to enter. Your cells are going to be immensely swollen up and they're going to die. They're going to explode, which we call lysis. So that's probably the most brute force one out of all of these. Pore-forming cytolysins is a bit more elegant, but they basically lead to the same outcome. All they do is that they produce proteins that they're basically proteins that insert into the phospholipid layer and then expand to form a little hole. And that hole is non-specific. So it'll basically just allow either water to exit or water to enter. Obviously, really important things like proteins and other large molecules will be able to exit, and it's effectively punching a hole, right? So this is again going to cause lysis in the host cell. These can also sometimes help bacteria to break out of vacuole. So if you have a bacteria, like in the previous slide, which is now trapped in a vacuole, and it's able to escape the lysosomes that are trying to bind with that vacuole, where is it going to go now? Well, it could produce these cytolysosines or cytolysins. It's going to make a hole in the vacuole, and then it's going to pop the vacuole, go out into the cytosol. It's going to then pop the entire cell and then go out into the bloodstream. So super, super useful, not just for entering or destroying cells, but also for getting out of cells as well. Again, if you don't remember anything, Staph aureus is probably the most important one. It produces alpha hemolysis, which is just another pore-forming cytolysogen, but it's mostly, I think, for red blood cells. So you can even get anemia because of the risk of Staph aureus just gradually destroying all the red blood cells in your body. And then Clostridium perfringens, you will come across this later on in MSK. It produces another alpha toxin, but this time it's a phospholipase. And that leads to destruction and necrosis of tissue, which can cause gas gangrene. I would not encourage you to search that up. Probably don't search up gas gangrene. It's a very, it's not a great site. You will come across it in MSK diseases though. I think I'll be taking you through MSK diseases. So we might be able to have a look at some of those pictures later on. Intracellular toxins, again, not that important to remember. I think the next slide will go into 2 specific examples, but they contain 2 components, and it's called an AB toxin for that reason. The A component, so this is the red one that's visualized, it's the thing that's actually causing an effect. It's the one that's doing the damage. And so A stands for active. The B component is basically just allowing the toxin to be able to get into cells. So it's the binding component. It tricks your host receptors into letting the bacteria in or the toxin in. And then the A component does all the work on the inside. Now, although the A, B toxins, of course, they work together, each component, they don't have to be found in the same ratio. There are toxins that are like AB3, AB5, AB7. So that indicates that for every 1 A component, there might be 7 or 8 B components. And that is a good transition into this next slide. The diphtheria toxin and the cholera toxin are both types of AB variants. The diphtheria toxin is a bit simpler. So it's just a normal classic AB. Diphtheria, by the way, the bacteria is Corynebacterium diphtheria. You might know that people who have diphtheria have difficulty breathing. It's sort of like an infection of the throat. And the reason why it is able to do this is because the A part is an enzyme. And what it does is, I think this diagram here pretty much sums it up. It adds an ADP ribose molecule to the ribosome elongation factor. So thinking back to translation and transcription, if this happens, it's basically just adding a block to that factor. So it's going to stop the ribosome from being able to produce those proteins that are crucial for those cells to remain alive. If that's the case, all those cells within the throat are going to start dying. It's going to cause a buildup of necrotic tissue over time. This is a very, very fast acting toxin. So it's a medical emergency. And once you've got this necrotic tissue forming, it's going to form a sort of layer over the airways, and it's going to obstruct the airways. So definitely an emergency. All you need to do is sort of pierce through that necrotic tissue layer to be able to allow breathing, and then give them antibiotics and things to get rid of the infection. The cholera toxin is more complex, produced by Vibrio cholerae. It's an AB5 mechanism. So as I said, for 1A, it's going to have 5B subunits. Not for any specific reason. I think it just makes it easier for it to enter into cells. So it's a compound toxin, and it leads to an increase in cyclic AMP, CAMP. And you can also have a look at sort of the biochemical mechanisms by which this happens. It's quite complex and intricate, but it will lead to a disruption of the ion balance. Basically, the net effect is that it's going to cause massive electrolyte release. We know that typically water will follow electrolyte, so it's going to cause a lot of water release as well. And if you have that, you're going to get what is typically called rice water stools. So if you search this up, again, not a pleasant thing to look at, but you'll get stools that sort of look really, really, really watery, and they'll sort of look yellowish white as well because of lack of absorptions. And if you have a lot of loss of water, you're at risk of dehydration. So this is very, very, there's a strong risk of death if this is not treated as quickly as possible. So both of these are quite difficult to manage, but once you recognize the toxin or the bacteria that's causing the production of toxins, which is causing the symptoms, then it's very effective and easy to treat. Neurotoxins. So again, not too high yield. You will come across this in MSK, I believe. These are enzymes that act on neurotransmitters and lead to neurotoxic paralysis. There are 2 major ones that you should be aware of. The botulinum toxin, the one that's actually used in Botox, is going to block the release of ACH, acetylcholine, from the nerve terminals. So you can see it's sort of, obviously it's not like a sheath or anything that's attaching, but this sort of depicts that's blocking all of those vesicles from actually exocytosing and then attaching all those neurotransmitters from attaching to the cytoplasm of the muscle cell. that's the case, it's going to lead to muscle or flaccid paralysis. So flaccid paralysis just means that like if my hand was flaccid paralyzed, it just means that if I was to shake it around, it would just go like this, right? It's a little bit different from spastic paralysis, which is caused by tetanus. So the tetanus toxin, it blocks the release of inhibitory neurotransmitters. So basically you will get a mass release of neurotransmitters without any way to stop those neurotransmitters from being released. If that's the case, you might be wondering, why is it causing paralysis? The reason why is, if I had spastic paralysis of my arm, it's going to keep on getting activated to the point where I might, remember we talked about like contractions and like tetanus, unfused and fused tetanus. If I keep contracting, it's going to cause a fused tetanus whereby my entire arm is just constantly going to be contracted. It's going to stay like this forever. There's an image from like the 18th century or something, where it shows a man who's like curled up with his back sort of arched. And it sort of shows you that for him, it was sort of the muscles of the back, but it shows you how painful this can be. So you can have so many contractions that you will start to get tearing of the muscles. And it's very, very difficult to live with something like this. So it's causing uncontrollable muscle contraction. So if you see someone having paralysis, remember that there are two types, and this will indicate what sort of treatment you need to give them. Is it flaccid and therefore probably not requiring urgent medical care? Or is it going to be spastic paralysis, and in that case, a medical emergency? Okay. And then finally, sepsis. I believe the lecturer goes into this in a lot of detail because it's one of the under-recognized things that are happening in hospital systems, or at least people are not very well equipped with figuring out if someone is undergoing sepsis. There are a couple of terms that are useful to know. Sepsis is just a whole body systemic inflammation in response to infection. So if you have that bacteria that's able to escape from tissues into the bloodstream, or it's able to escape into your lymphatic system, and it's able to go to different parts of your body, then you've got a systemic inflammation now. And in that case, it's a lot more dangerous because you can have it invading into heart tissue, you can have it invading into brain tissue. So it's very important you get this treated as fast as possible. Septic shock is a little bit different. It is when you have sepsis and you've got all these immune cells trying to react all at once. And because they're releasing a bunch of cytokines, you're going to have a lot of vasodilation to be able to get blood to where the infection is happening, and therefore to be able to get immune cells to be able to permeate through and attack those bacteria wherever they are. But because you have a lot of vasodilation, it's also going to be followed with hypotension. So a very, very severe drop in blood pressure. And if you have a severe drop in blood pressure, that means you're going to have hypoperfusion of organs. In other words, you're not going to get enough blood to some of your vital organs. So if that affects the kidneys, you might get kidney-related symptoms. If it affects the brain, obviously that's quite distressing. It's a medical emergency, but it really depends on the different organs that you are affecting. If it's systemic, it's probably going to affect all of your organs equally. Endotoxic shock is very much the same thing, but it's just specific to gram-negative bacteria. So anytime a gram-negative bacteria causes septic shock, we just call it endotoxic shock. And that's through the release of their endotoxins when they die. There are a lot of indirect effects and direct effects that are happening. Most of them are actually indirect effects. And the reason why is because the bacterial toxins, they've done their job. It's actually now your host immune system and your host immune cells that are doing all of the damage. So they're kind of overcompensating for the amount of bacteria that are infiltrating into the tissues around your body. You can have cytokines, clotting factors, complement factors being produced. And interestingly, like even if you try and have fluid treatments, remember you have hypotension. If you want to try and get that low blood pressure to increase again, you might try and administer fluids. But that is not going to cure the underlying problem, which is the fact that your immune system is responding to bacteria. So you will need to first treat the bacteria, and then potentially the fluid treatment might work better. And the worst cases, as I said, you will have less blood flow to your organs, which can lead to multiple organ failure and therefore death. So anytime you recognize this, someone has a fever, they start to show symptoms that are not just confined to, like, for example, their leg, it's going to their hands, it's going to their neck and things like that. You're going to be suspecting sort of a septic shock response. And of course, like the problem has definitely increased beyond the original infection, wherever the site was. Okay, so it's under-recognized, but it's super important to remember. All right, and I think that's it for my section. I will address any questions in the chat just for the interest of time, but I'll pass it back to Janul, I think, to cover pharmacokinetics.
Yep, right. I'll just start screen sharing as well. All right, now we're going to be having a look at pharmacokinetics, which we've already covered last semester, but we're going to be adding a few extra ideas onto that, which will help put a bit of mathematical context to a lot of the stuff we talked about. So we're going to start off with first of all, what is pharmacokinetics? Well, it's all about what the body does to the drug. So we know that a drug has an effect on the body in terms of having a therapeutic benefit, but we also know the body is very much going to affect how the drug is distributed throughout the body. And that's by absorption, where it sort of affects how it'll be absorbed well into certain compartments of the body. Metabolism is all about how the drug is broken down into the liver, and sometimes the drug might be active in its metabolized form, which is also going to play into pharmacokinetics. And you also have distribution, which is all about where the drug will end up going in different parts of the body. And we normally want the drug to be in a high concentration at the target site, wherever that may be. And then finally, you have excretion as well, which is all about how the drug can be removed through excretion in terms of the feces, in terms of urine, as well as other outlets, which we'll be having a look at later on as well. Okay, so why do we care about pharmacokinetics? Well, the goal of this topic is, or the goal of this the study is to really try and achieve effective, non-toxic levels of drugs. So you want it to be effective. So it has to be above a minimum effective concentration to be considered effective, but it also has to be below a minimum toxic concentration, below which the drug is safe to actually take. So it has to be both therapeutically beneficial and effective in that range, but also it has to be non-toxic and safe for the patient to use. So that's why we have this narrow window between a minimum effective concentration and a minimum toxic concentration, which we call our therapeutic window. And our goal is for the drug to remain within that area to have maximum benefit. And the problems that sort of we face in pharmacokinetics is that with absorption, we need to make sure that we're absorbing enough of the drug to actually reach that top level where we're within the therapeutic window. But then we also need to account for the fact that our body is going to be constantly trying to eliminate, metabolize, and get rid of that drug. So we have to figure out ways of avoiding that if you want to keep it in the body for longer and have a greater effect there as well. Okay, let's talk about distribution first of all. So distribution is all about how does our body distribute the drug throughout its compartments. And that depends on three main factors: moving across membranes, because again, all of the compartments are separated by different membranes; delivery to tissue. So it's all about how the drug will be delivered to the tissue via the blood. So blood flow is going to have a very important effect, as well as staying at the site. You have to have that drug being able to stay within the site rather than being taken back away by the bloodstream to other areas. So some sort of adhesion or binding factors are going to allow it to stay stuck or stay adhered to that target site. Movement across membranes has already been covered previously, which is all about the size of the drug. So it has to be small enough to be able to diffuse across the membrane. Lipophilicity, so the more lipophilic the drug is, the more easily it can diffuse across membranes. And degree of ionization, which I think we already covered last semester, so I won't go into it again. But usually the drug is most lipophilic or most able to cross membranes when it's in its unionized form. So that's again pH dependent, as well as degree of ionization dependent, or the constant of ionization dependent. But again, that was covered last semester, so we won't go into it this semester. Instead, what's going to be covered on this slide is plasma protein binding. The idea that when the drug is within the bloodstream, it can often be bound with other protein carriers, which inactivates the drug and allows it to exist within the blood for longer. So that's one thing that can prevent it entering the site sometimes. But also within the tissue itself as well, the drug can be bound up and found in a bound form and a free form. And that also allows the drug to stay within the tissue. So there's sort of two of those aspects there, which are going to affect the distribution of the drug. All right, now we're going to come across a term which is a little bit confusing because it's not actually really a volume, but I explain what this term volume of distribution means. So volume of distribution is a volume into which a drug appears. So the keyword there is appears, that it appears to be distributed in the body with the plasma concentration. So basically what we've done here is taken the concentration equals mass over volume formula, rearrange it for volume, and we try to apply it to the context of the body. So the volume of distribution, or the volume which the drug occupies, is going to be the total mass of drug which is given to the body, so the actual dose you're given to the person, divided by the concentration of drug in the plasma. Now, the reason why this is actually an inaccurate estimate is you're dividing the total amount of drug in the body, so that's going to be the dose you're giving to the person, by the concentration of drug in the plasma. So you're comparing the whole body to just the plasma. And the thing that can go wrong with that is that often the drug is in different concentrations throughout your body. So the plasma concentration of the drug may not reflect the concentration throughout your whole body, which is why it's an inaccurate measurement. But nevertheless, it gives us a rough estimate as to whether our drug is very well distributed or not as well distributed. So it's not representing anything real, but it's linked with distribution in a very tenuous way. And again, a diagram here is showing that same idea up top. And in terms of what this value actually means, so again, as I said before in the previous slide, the higher the value, the more spread out this drug is throughout the body's compartments. So it's not a physical volume, but it's linked to the amount of distribution to the body compartments. And again, a refresher from last semester as well, the body compartments refers to the interstitial fluid and intracellular fluid. So the drug can be present within the blood plasma, or it can diffuse out into any of these different compartments and exist there as well. So the higher this constant is, the higher the chances that the drug is not going to be just within the plasma, but also entering into the interstitial fluid and maybe even entering into the cell to have a certain effect. All right, so we can get that same equation there and rearrange it for the dose. So volume distribution equals dose divided by drug in blood, the concentration of drug in the blood, and rearrange that to get the total dose or the loading dose you need is equal to the volume distribution times the concentration of drug in the blood. Now, what's the use of this? Let's say, for example, if we go back previously, we had this idea that we want to keep the drug within a very narrow range. We want to keep it within the therapeutic window. So we have sort of a target or desired concentration of blood that we want, of drug that we want in the bloodstream. And so that target desired concentration we can achieve by using a certain loading dose. And that loading dose you can figure out using this equation over here. Now, for that VD value, the volume distribution, that's usually a known constant for the drug, which is labeled on the drug details on Pharmacokinetics websites, where they sort of detail the VD values for different drugs. And that can be used to estimate the loading dose needed to actually achieve the target desired concentration of drug in the plasma. Okay, now let's talk about metabolism and elimination. Remember, these are processes that are going to reduce the concentration of drug in our blood, bringing it down by metabolizing that drug and then getting rid of it through secretions. So there's generally two main mechanisms for achieving this. Lipophilic drugs, which are not as water soluble, have to first be metabolized by the liver before they can be cleared. But let's talk about the simpler mechanism, which is that hydrophilic drugs, so drugs that are able to easily dissolve in water, can actually be relatively easily removed because they can just be dissolved into the urine and removed via renal clearance in the urine. Whereas those lipophilic drugs, which you said before, which are not going to dissolve as well in water, they have to be made more water soluble. So they have to be metabolized usually by the liver primarily. And then from there, it can either then be cleared via the kidneys, so in the urine, or the liver might actually excrete it with the bile. And so it'll be excreted in the stool as part of the bile that was excreted into the digestive tract as well. The problem here, though, is that often the body reabsorbs a lot of the bile and does reuptake with that as well, which means the drug can be continuously cycled in this process, gradually removed. But again, the key idea here is actually metabolized first by the liver before it can go into this hepatobiliary clearance. All right, so metabolism-wise as well, we have two general types of metabolism that can occur. But both of these metabolism phases, their goal is to take a lipophilic drug and make it more hydrophilic. So make it less lipid soluble and more water soluble. One way you can do that, which is the phase 1 metabolism, is through catabolism. So basically breaking down that molecule into hydrophilic products. So we get a lipophilic product, substrate, we break it down into hydrophilic products, which can then be easily cleared. The other phase, which can potentially happen as well, is anabolic. So what that means is you're breaking down the compound. So you're building up a compound, right? And the way you do it is you get the lipophilic drug and you add to it another polar compound, which then makes it overall more polar. That's another way that you can address the issue of it being lipophilic and eliminate it from the body more easily. All right, so one thing also on this slide, which is mentioned in the slide notes, is that, and also in your lecture, is there's a class of enzymes called the CYP450 genes, or the enzymes that they code for, which are important for these phase 1 reactions. And in particular, I'm mentioning that because in your slides as well, they mentioned this drug called St. John's wort, which is an alternative medicine that's taken by some patients, and it interacts with these CYP enzymes, and it can make them more active, and therefore people who use this alternative medicine will have that enzyme being more active and being able to metabolize drugs more rapidly, and therefore you may have to alter dosage depending on the amount they're taking as well. And another final thing as well is that with excretion, we've shown here excretion via stool and excretion via urine, or sort of through the digestive tract and the urinary tract. But there's actually other ways you can get rid of drugs, for example, through sweat, tears, milk, and the breath even. So there's multiple ways that excretion is happening. We sort of fixate more on the liver and kidneys as the primary sites of excretion and metabolism. All right. The next slide is the kinetics and pharmacokinetics, which is talking all about how the drug its concentrations are changing inside the body, and how exactly mathematically we can correlate that. So generally speaking, we think about two different ways the drug can be eliminated. It's zero order elimination and first order elimination. With zero order elimination, the idea is the drug is being eliminated at a constant rate. So you can see over here that the amount of drug being removed per unit time is fixed. It's 2.5 units per hour. It's not changing. And as a result, the amount of drug in our plasma is going to go down at a constant rate with this flat line. So the rate of clearance is proportional to a constant. And so therefore it's zero order because it's proportional to the concentration raised to the power of zero. So just a constant there. And you can see as well that as a result of this zero order elimination, the time or the half-life, which is basically how long the drug lasts, or how long it takes for half the drug to be eliminated, is actually not a fixed value. So if you look over here at the concentration being 6 and then it being 3, the time to go from 6 to 3 is this long. But then to go from, it should be from here. So 4 to 2 is not long, but from 2 to 1 is reduced. So either way, from 6 to 3, it's a certain time, but then from 2 to 1, it's a smaller time. So the half-life there isn't a fixed value, which is in contrast to first order elimination, as we'll see in a second. But the reason that we actually have zero order elimination, the actual reasoning behind it is that the enzymes involved in eliminating the drug or metabolizing the drug are actually saturated. So for example, this drug could be transported across the membrane to be removed by a certain protein, and that protein might be completely saturated, which means that the more drug you have, there's not going to be any change in the removal rate because there's no more enzymes to actually help facilitate that process. So that's why we have zero order elimination. First order elimination is the opposite idea, where we actually have an increasing rate or even a decreasing rate of elimination of the drug. In this case, we have a decreasing rate. So what's happening is that the less drug there is, the less elimination rate there is, because as the drug goes down, so too does the effectiveness of the enzymes, because there's less substrate for it to break down. Whereas over here, there was just so many drugs anyway, so many drug molecules anyways, that it didn't matter that even a small amount was removed, because it was still going to be saturated with those enzymes. But the rate over here is proportional to the concentration in the plasma raised to the power of 1. So you can see over here that the rate is actually changing rather than staying fixed. And it's changing as a proportion of plasma raised to the power of 1, which is why it's called first order elimination, because you're raising it to the power of 1. And over here, the half-life is fixed, which is kind of hard to see without actually drawing up lines. So I've sort of drawn the times for it at 6 and for it at 3, and then for it at, it should be at 1.5, but it's at 2. But if you're looking at 6 and 3 and 1.5, they're roughly the same value, which shows that the half-life is actually fixed, as opposed to the other one on the left here, where it's actually changing. So the half-life of this can be very easily predicted and written down, whereas the other one, not so much. Also with first order elimination, it's a consequence of having abundant enzymes. So as the amount of drug is being reduced, the effectiveness of those enzymes is going to increase, and that they can break it down faster as well. Okay, next slide, we have steady state, which is something which was mentioned in your lecture as well, but it's the idea that we want to have the drug sort of reach a steady state where it's within the therapeutic range, and it's staying within that therapeutic range steadily for a certain period of time to have a therapeutic benefit for the patient. So we can do this two ways. The simplest way of doing it is with continuous IV infusion of the drug. And what that means is you just put an IV fluids into the patient with the drug, and you can gradually reduce the flow rate. So you can keep on pumping in the drug until you reach the steady state, and then you can gradually reduce the flow rate until you have just that flat line where it's within that range, and then turn it off whenever the drug has effect, or when it's done having its effect. So at this steady state up top here, the flow in of that drug is balanced out by the elimination rate, which is why it's staying steady and not going up or down, or no net increase or no net decrease. It's just a net zero there. However, in reality, not all drugs are going to be given through IV infusion. In reality, a lot of the drugs are going to be given orally, for example, in which case you have to actually use repeat dosing. Because what happens is each time you give a drug orally, it causes a spike in the drug concentration in the blood once the drug is absorbed, but then the drug starts to be metabolized by the body, right? And so you're going to have to keep on repeat dosing until you spike up and then come down, and spike up and come down until you finally reach the therapeutic range. And then you reach steady state once the elimination rate and the dosing rate is going to be pretty much balanced out. Now, what is the application of knowing all this? Well, if you know that larger loading, if you know that your drug is going to be eliminated once you put it into the person's body, what you can do is you can use a larger loading dose at the start to actually reach steady state faster. And it's just shown on the image on the right over here. If you use a smaller loading dose, it takes more time for your drug to actually reach the therapeutic range and would be within that toxic, below toxic, but above subtherapeutic range. However, if you use a very large loading dose, you quickly get up to that range straight away, and then it can stay within that range for a longer period of time. And this is ideal for emergency scenarios where you want to quickly reach the therapeutic when applying it, for example, in ER situations. All right, and there's also a number of equations that I mentioned for pharmacokinetics, which are listed throughout your slides, but it's sort of succinctly brought together in this pharmacokinetic triangle where all the constants that you're going to be working with are drawn along this triangle, and along the border, to get these values, just multiply it across. So for example, rate of elimination equals this constant K, which again is mentioned in the lecture notes as well, times AB. And you can just go across the border of the triangle to get the equations. And to get the other equations, you go within the triangle over here to get K equals CL over VD. Usually they sort of give this to you for questions when you're going to be applying them. I'm not too sure how it will work for your year level, but at least in our year level, when we were given workshops and activities to work on this, they were usually provided to us. And yeah, you can use these equations to mathematically quantify some of these values as well. All right, now we're going to have a look at the MSK exam. So that was pharmacokinetics, and feel free to ask questions in the chat if you have any about that. It's something which you'll get sort of understand more as you apply it to the workshop which you're going to be having. But next up, we have an MSK exam. But this time, instead of doing the shoulder, we're going to be having a look at the elbow joint, the wrist joint, and the finger joints as well. So let's start off with, again, content-wise, we're going to be looking elbow, wrist, finger joints. And we're looking at all this together at this stage, at least, because normally whenever you're examining any joint at all, you're going to be examining the joint above and below just to check for pathologies that could be there that are affecting nearby joints. All right, so same as usual for our examinations, we have hand hygiene, introduction, all of that stuff, except for the elbow joint, you're going to ask for either the removal of the shirt, if you want to inspect the shoulder joint as well, or you might just ask them to put their sleeve up so you can get access to the elbow, so you can have a look and feel around it to check for any pathologies. Whereas with the wrist and hands, again, you don't have to be as invasive. You can just ask them to remove any gloves they have on or remove any ring just to be able to assess those joints there. All right, now let's get to the interesting part, which is looking at the elbow. Now, looking at the elbow, you're going to notice a couple of important things, which you want to point out to the examiner as well, whenever you're sort of listing off these pathologies. So first of all, as usual, you want to comment on the posture, if they're using any walking aids, if there are any visible pain, if they have any deformities or injury, and common on the body habitus as well, which is all again mentioned in the notes at the bottom. But in particular, for the elbow, as opposed to the shoulder, you want to look for a couple of extra things. You want to look for gouty tophi, which is shown over here. And that's sort of an indicator of later on. You want to look for enlarged bursa, so this thing over here. And enlarged bursa can be an indicator of olecranon bursitis, which is this bursa at the back of the elbow, which helps reduce friction whenever you're moving your elbow. And that can be inflamed. And as a result, it'll show up as this red and tender location on the elbow of the hand, on the elbow of the patient. And you also have rheumatoid nodules. And rheumatoid nodules show up as these nodules on the back of the hand over here, as well as on the elbow as well. So you're going to be looking at them in two locations. And again, as the name suggests, rheumatoid nodules are indicative of rheumatoid arthritis, right? And you also have elbow effusion, which is usually where you have a little bit of fluid build up in that area, so a bit of effusion. And you can usually tell it's elbow effusion by touching it. It might be tender, but usually it'll be easy to move, and sort of you can feel fluid underneath the skin there as well, which is why you can tell it's effusion as opposed to just any sort of ordinary lump. And those are the four main things you want to look out for. In terms of look out for, normally what that involves with a lot of your exams is that often the patients you're going to be looking at are not going to have this. And so all you'll be saying is, I'm not seeing any gouty tophi, I'm not seeing any enlarged bursa, I'm not seeing any rheumatoid nodules. So you're just going to be saying that you can't see those things as you go along. All right, now with the wrists and hands, when you're looking at those, there's a number of things you want to look for here. So again, the general stuff you'd always look for in any exam, but you're also going to be looking for rheumatoid nodules here again, but within the fingers this time. Usually in the digits, you might see some rheumatoid nodules and point out that you can't see them at all. And also on the right here, on the dorsum of the hand, on the back of the hand, you might see cysts called ganglion cysts. And normally they're sort of benign and harmless growths, and they might not cause any pain to the patient. But in some cases, they can actually compress the tendons below. And because we're looking at the back of the hand here, it will impact extension, because the extensors come through here to enter the hand as well. So you want to mention that you're seeing no ganglion cysts there as well. And then the final thing, which is probably an important one to keep in mind, is the deformities of the fingers that can occur. So you have mallet fingers, Routenier's deformity, and Swan neck deformity. So they all present differently in terms of how they actually cause the flexion of the joints of the finger. But generally speaking, mallet finger and Routenier's deformity are caused by trauma. Usually, for example, you might know of the common injury where if you are throwing a basketball around, that basketball can land straight on the finger and cause that finger to be bent at a certain position. And if that tendon is permanently damaged, then it might be stuck in that position until it heals up properly. Whereas Swan neck deformity is usually an indication of rheumatoid arthritis affecting the joints there as well. And that's the three main things you're going to be looking for within the wrists and the hands. Next up, you also have palpation. So it's very similar to the previous example with the shoulder. You're going to be looking at temperature. So you're going to be using the back of your hand to feel the temperature of the joint at the elbow and at the wrist and the hands. And usually you're going to be comparing both sides and seeing if they're normal, or if they're a bit too cold, or if they're very hot and swollen, for example. And again, you want to feel around for any swelling and look for swelling. Feel around for muscle bulk. If there's a particular bulk of muscle that you can feel is prominent, you might want to note it down or tell it to the examiner. Tenderness. So whenever you're feeling along the elbow or the wrist and the hands, you want to look at the patient's face at the same time as well and ask them, are you feeling any pain as I do this? Or look for any grimacing on their face, and that'll sort of indicate to you that that's an area of tenderness. Surface anatomy landmarks wise, they're going to be different for both the elbow and the wrist. So we're going to be going through both of them. So with the elbow, there's only really 3 or 4 main things you want to take a look at. With the elbow in the humerus, you want to look at the medial epicondyle and the lateral epicondyle. So that's the epicondyles are the distal end of your humerus, where it connects to the elbow joint. And there's going to be a lateral prominence, so on the outside of your arm, and a medial prominence on the inside of your arm. And those are the epicondyles you want to be able to palpate on the patient. And the reason we palpate it usually is that upon palpation, you want to see if there's any tenderness there at all. And that will indicate if they have either golfer's elbow or they have tennis elbow, which again is mentioned in last week's anatomy slides. And you have the ulnar groove here as well, which can be sort of palpated, where it contains the ulnar nerve. And so pressing that area is going to really cause tingling in the person's arm. And the final thing is in the ulna, so the ulnar bone, you want to feel the olecranon process, which again, you can usually palpate very easily as coming out at the front. This very bony prominence here is the olecranon process, that sort of very distinctive kink of the elbow right there. In the wrist and the hands, you're also going to be palpating a number of important landmarks. So you're going to be feeling the wrist joint and feeling for the ulnar and radial styloid process. So at the distal end, you have the styloid processes. So that's the sort of outer bony prominences of the radius and of the ulna. And you're also going to have listus tubercle, which is not labeled on here, but I'll sort of include in a separate image. And in the wrist, you very importantly want to be able to palpate the individual carpal bones. Now, it's a very tricky thing to distinguish between the individual carpal bones. So I think you'll have a video link to it in your clinical skills notes, but very roughly, they're marked out on here. And the way that I normally think about it is I start off at the base of the thumb where the scaphoid is, and then I work my way across from there. So the base of the thumb where the scaphoid is, right, just about there. And then you go across this row over here, just on the back of the hand. So you go across here till you get the lunate, the triquetrum, pisiform, and then you go up to the hamate, capitate, trapezoid, and trapezium, and move your way along like that. So again, the video will make it a bit clearer as to how you can actually individually distinguish those, but it's very much something you can only learn by doing. So definitely have a go, practice with maybe one of your friends or even on your relatives and see how you go about with that. Okay, now let's talk about movements. So now we're going to be moving the elbow joint and the wrist and finger joints, and we're going to be seeing how we can do that both passively and actively. So with the elbow joint, you can only really have 4 movements there. So there's flexion, it back down, and then supination, so holding a bowl of soup, and then pronation, bringing it back down. And with all those movements, the respective angles of movement are shown there as well. And with all of them, when you're doing it both passively and actively, you want to look out for crepitus. And you can, when you're doing it passively, where you're actually moving the patient's arms, you can usually feel that crepitus as a grating sensation when you're moving their arm. But also they might notice it as well and let you know about that feeling in their arm or the elbow joint. And with the wrist and hands, there's a couple more movements there. So with the wrist, you have 4 movements there. You have wrist flexion, so bringing your wrist back, cocking your wrist back like that, and then wrist extension, bringing it back the other way. So you're flexing and extending. You also have ulnar deviation and radial deviation. As the name suggests, you're getting your wrist and you're deviating it to the ulnar side, which is the pinky side, or deviating it to the radial side, which is the thumb side, right? That's ulnar and radial deviation. And if you try doing it on your own as well, you'll see that you can do a lot more ulnar deviation, but a lot less radial deviation, which is down to the anatomy of the wrist joint, which you mentioned before. And with the fingers, you can do a couple of broad ranges of movements. So with all of your fingers, you can flex them and extend them, but you can also flex them at the individual joints. So at the metacarpal phalangeal joints, the proximal interphalangeal joints, and at the distal interphalangeal joints. So you can sort of have a look at that in the patient as well by having them do it themselves, having them do it passively first by you individually doing that, and then doing it actively as well. And then you also have finger abduction and adduction. So abduction, adduction, which you can access. And then finally, you have opposition and reposition. So again, just bring the thumb and pinky together is opposition, and reposition is putting them back where they were. And again, when you're assessing those, you want to look for crepitus there as well. But finally, we come to the special tests of the elbow. So a special test of the elbow, there's 2 varieties. And I think the diagrams here might be slightly different to what you have in your own clinical skills notes, but they're pretty much the same idea in terms of what they're testing. So if you remember from your anatomy from last week, we learned about the forearm muscles, and we learned about how in the anterior compartment, you have all your flexors, and in the posterior compartment, you have all of your extensors largely. And the anterior flexor compartment originates on the medial epicondyle, whereas the extensor compartment originates on the other epicondyle. And so what you're doing here is you're testing those epicondyles by having the patient resist flexion or resist extension. And you can see those two tests over here as well. So there's resisted wrist extension test, which is testing the extensors on the back of the hand, and the wrist flexion test is testing the flexors on the front of the hand. Those are the two ones you want to test for. And again, we're testing this resisted movement and checking for pain the whole time. So if the patient reports any pain, it probably means that those groups of muscles, or at least where they're inserting, might be affected. And you also hold that epicondyle in place so that there's no involvement of the other muscles, which can move the arm as well. You have a number of other important tests. So you have the carpal tunnel tests over here. So the carpal tunnel test, you only learn about two main tests, which is the Phelan sign and Tinel sign. Phelan sign is getting a patient to put their arms like this and hold that for about 30 seconds, 60 seconds, however long you need, usually about 60 seconds. And in that period of time, because you're compressing the carpal tunnel even more in this situation, because of the way you're cocking the wrist back, then what happens is that it causes the sensory paresthesia, which is going to occur in the median nerve distribution, right? And Tinel sign is shown down here as well, which is a similar thing, where instead of doing this with the patient, you tap them on the wrist around about, on the distal wrist, I think, it's just over here, which is around about where the median nerve passes through. And as you tap there, it will elicit the same sort of symptoms, which is that sensory paresthesia over that distribution. And finally, you have your hand function test, just to generally test the function of your hands and the muscles there, so the thenar eminence and the hypothenar eminence and the lumbricals, as well as the interossei. So with these tests, you have the grip strength test, which is all about getting your fingers like this, and getting the patient's fingers like this and asking them to resist you pulling on them, right? That's the grip function test. Then you have the key grip test, which is usually done with a key, but often can do with a piece of paper as well, where you get the patient to get the piece of paper and put it between their thumb and index like that, and you pull it out and see if they can resist that movement. And that's called the grip strength, the key grip test. And you have the practical test as well, which is actually very straightforward. Just ask the patient to write something down, and that writing checks the dexterity and the use of their fine finger movements as well. And then you finally have the opposition strength test, which is all about getting your patient to put their fingers into opposition, so thumb and pinky together, and then seeing if they can resist you pulling them apart from each other. That's the opposition strength test as well. All right, those were the special tests. And again, with all of these, you'd be saying, with all of these special tests, at least, you'd be doing them only under certain conditions. Like, for example, if you suspect carpal tunnel or suspect a hand function deficit there. But if you have any further questions about any of this at all, or about how you perform any of these examination components, let me know in the chat and I'll try and get back to you.
Easy, okay. So yeah, give me 1 second to share. I know your mightiest point is starting soon, and it's been quite a long presentation today, although a bit shorter than our previous ones. So I'll try and keep this one short. It's also not super high yield because it's HEP and it's a sort of more minor topic within HEP, but it's still examinable. So I'll do my best to give you a good overview. All right. So when we talk about mental health, this is where we actually talk about our health as doctors, right? And as medical students for that matter. So the first thing we need to talk about is our sources of stress. So a lot of med students and a lot of doctors are pretty stressed. Why do they have this stress? So there are exogenous sources of stress. So you have, you're putting in a new environment. There are other things in your surroundings which are causing stress, inducing stress in you. There's endogenous stress. So you are causing stress in you because, say, you have high expectations for something, you're a perfectionist, that sort of thing. Very common in med students. Incongruity, where you expect something. This is especially when you go to clinical practice. If you expected it to be like something and then you found out the reality of being on the wards is something different, then that's the sort of source of stress. And inconsistency. So this is another big one. As you probably have heard a few times by now, med school is not necessarily what you'll be using when you're actually out there. And that can be a source of stress as well, because it feels like you're unprepared or unsure. So fixing these, big things that we can do just individually for ourselves, things like setting realistic expectations and being able to identify when we're going to have a mismatch between our education and clinical practice, and things that we can't do ourselves. So things like support and counseling. So a big theme here is that you do need to acknowledge when something is beyond your individual ability to address. Burnout, you'll probably have heard this at least one time, whether it be in med or something else, but it's basically you're going really hard, you're doing a lot of work, you're doing really well, and then you just crash. So you lose energy, you lose motivation, you lose drive, and you sort of are stuck in that state, and the quality of your work really drops off a cliff. So this is very bad for us for a number of reasons. So first of all, it's bad for you as a doctor because, obviously you've crashed. It's also bad for patients because we have like the risk of administrative errors, poor handovers, which can lead to patient injuries, misdiagnosis, all sorts of stuff goes up because, as I said, you've lost motivation, you've lost energy, you're not working at 100%. So we try to avoid burnout. And resilience is basically a shorthand or an umbrella term that in part addresses how we can deal with burnout. So dealing with stress instead of unhealthily like burnout, where you just go hard and then you crash. Resilience is basically the opposite. So how we can control that and stay working at a sustainable level, basically. So it's sort of the opposite of the stuff that leads to burnout, basically. So you need to understand yourself. So first of all, know when something is outside of your capabilities. Don't kill yourself trying to do it. Don't overstress yourself or make yourself too anxious. So just being very aware of ourselves, which is part of why we have the whole mindfulness push. Being aware of what you are, what you can handle, and not exceeding that. Support networks and coping strategies can help as well. And again, mindfulness, like everything else, in help. Medical culture. So this can be a big source of stress. So there are good sides to medical culture. So that's meant to say concerned. We do place a lot of priority on people who work well, who care about their patients, who do a good job for their patient, that sort of thing. That's good, but it can also lead to sort of a darker side of things, where it can be, among other things, very prone to promoting overwork and basically exceeding those limits. So we talked about resilience, a major factor of that being that you stay within your limits. Medical culture can often glorify things like overworking, which lead to exceeding those limits and then burning out. And that's unhealthy. So there are good sides and bad sides to it. Another big thing is hierarchy. So, we talk a lot about the whole progression, the hierarchy of people within medicine, and that can be a bad thing because it does lead potentially to things like bullying and power abuse. All right. So emotional intelligence. So this is basically your ability to do a whole bunch of things. So there's yourself. So you need to be able to understand other people and interact with them. So empathy and social awareness or skills. You need to understand yourself as well. So being able to know what's going on in your head, to deal with that in a healthy way, and to motivate yourself. So high AI is a good thing. It can help you a lot of things. Low AI is a bad thing. EI is not fixed, right? The same as IQ, which is sort of its counterpart in terms of pure academic or analytical intelligence. It's not fixed, it can be trained, and you should aim to do that. So that's a big part of why we go through all the stuff we do in HEP. Yeah, so you're aiming to improve this because it'll help you deal with yourself and deal with others. And I think this is the final one. So basically the overarching message here, so what are the strategies that we can use? So things like resilience training to improve our ability to deal with stress instead of burning out. Well-being programs, which help us get that sort of more holistic scale of things, dealing with stress, eliminating stresses from our lives, managing expectations, all of that. Mindfulness, like everything in HEP, behavioral activation, and intervening with peers. So again, the other thing that we'd like to stress here, both in a HEP level and also personally to you guys, is that sometimes there are things that you can't handle yourself. So don't go into med or really anything that you do thinking I'm self-sufficient. If a problem comes up, I have to handle it myself. Sometimes there are things that you can't handle yourself and you do need to seek help. So what we want to do is be aware of that, be able to identify that, and then be willing to go out and say, okay, this is too much for me, I need help. And that's going to be a lot more healthy than trying to deal with it yourself and causing a greater problem, which you will then eventually inevitably need help to get out of anyway. Yeah, that's the last slide. So yeah, thank you guys for sticking around. We'll let you go, hopefully have a little break before your Muddiest Point lecture. Thank you to everyone who's been using the Curious Cat. Please continue doing that because it's quite useful. Really centralizes everything and lets everyone see and benefit from the questions. So yeah, we'll see you next week at the same time.
Thank you.
Hey, everyone.
Hi, everyone.